In this first part of Lecture 2, we're going to talk about cranial nerve 6, the abducens nerve. The nerve itself is quite simple. Where students get confused is the connection between this nerve and cranial nerve 3. So the abducens nerve contains voluntary motor neurons. It only controls one muscle, the lateral rectus muscle of the eye. This muscle abducts the eye or pulls the eye laterally. Its nucleus is located medially in the dorsal aspect of the tegmentum of the caudal pons. This YouTube video might help you now that you've had the 3 cranial nerves innervating extraocular muscles to understand their function better. So recall that cranial nerve 3, oculomotor, innervated 4 of the 6 muscles: superior rectus, inferior rectus, medial rectus, and inferior oblique. The cranial nerve 4, trochlear nerve, innervates the superior oblique. And now we have lateral rectus innervated by cranial nerve 6, abducens. And that's why it has the name abducens, because it's responsible for abduction of the eye. If I have an injury to the abducens nerve, we have a medial strabismus, which means when you're looking at the person, their pupil, instead of being centered, is closer to their nose. And that is because the medial rectus, innervated by oculomotor nerve, is working, so there's some tone there, but the lateral rectus is paralyzed. Again, anytime we can't line the eyes up together, we're going to have double vision. So the person will have diplopia when gazing towards the affected eye, because if I had, let's say, damage to my right abducens nerve, and I'm not able to abduct my right eye, when I go to look to the right with my eyes, my right eye won't move to the right, but my left eye is moving to the right, so I can't get my eyes to line up. Because my medial rectus is working, if I look to the left, both eyes move to the left, and so they line up, and I don't have the double vision. Again, I'm not going to ask you to tell me how they compensate. This is just here for your information. Should you have a patient with one of these injuries, you can go back and go, oh, they turn their head to the side that's not working. And that makes sense, because if you can't look to the right with your eye, if you turn your head to the right, you can keep your eye closer to your nose to see what it is that you want to look at. They also would have an inability, again, to abduct the eye beyond midline. Between all the muscles, we can manage to get this eye to midline, but we can't get it past midline. So that's kind of the key thing. It's not that there's no abduction, but there's no abduction beyond the midline. This link takes you to where you can see somebody with the cranial nerve 6 palsy before and after treatment, or if I recall, there might be some images of individuals who have not had treatment, but it's not a before and after. If we damage the nucleus for the abducens, this gives us a different picture. We get everything that we talked about. They'll have a medial strabismus. They'll have double vision when they look to the affected side. They will not be able to abduct their eye beyond midline. And they'll also have a lateral gaze paralysis, meaning that in addition to not being able to abduct the eye beyond midline, that the eye of the affected side, the opposite eye is not going to adduct beyond midline. This is only going to happen during a voluntary movement and in a horizontal direction. So if you put your finger in front of the person and ask them to follow your finger, and they have a right abducens nucleus that's been damaged, and you have asked them to follow your finger, and you take your finger to their left and they follow with their eyes, that's not a problem. When you bring your finger to their right, you'll see that neither eye goes past midline. So if I damage the abducens nerve itself, while the right eye would not go past midline as my finger moved to the right, the left eye would. But if I damage the nucleus, then the left eye doesn't go past midline either. Now the left eye is controlled, adduction is controlled by cranial nerve 3, and that's way up in the midbrain. I'm way down in the bottom of the pons, so this isn't making sense. Well, there's a nerve that connects cranial nerve 6 to cranial nerve 3. And that nerve, when you stimulate cranial nerve 6 to abduct the eye, that nerve tells cranial nerve 3 that what you're doing, so that your other eye will move with together, so that your two eyes will move together. So that when you look to the side, we want both eyes to move at the same time. That neuron that is telling cranial nerve 3, okay, we need to adduct because our other eye is abducting. That nerve has its cell body in the abducens nucleus. So when I damage cranial nerve 6 abducens nucleus, I'm actually damaging both the neurons from the abducens nerve and these second group of neurons that are giving instructions to cranial nerve 3. These are called internuclear neurons because they're running between two nuclei, between the nucleus of the abducens nerve and the nucleus of the oculomotor nerve. They're traveling in a tract called the medial longitudinal fasciculus, or MLF. The medial longitudinal fasciculus is quite long and complicated, so we're only talking about a small piece of it. That medial longitudinal fasciculus actually goes up into the brain and sends neurons to lots of places we're not going to discuss. So I just want you to know this one group of neurons in this fasciculus. So here's a picture showing what's happening. We have a group of neurons in the inferior pons called the horizontal gaze center. So this is like our controller of moving our eyes side to side. Okay, so neurons there are activated. And so they stimulate both the abducens nerve, you can see the cell body and the nerve there in red, and stimulate the internuclear nerve, whose cell body and axon is shown in yellow. So they stimulate both of those neurons. The abducens nerve goes to the lateral rectus of the ipsilateral eye and would cause that eye to move laterally, to abduct. At the same time, the internuclear neuron travels up the medial longitudinal fasciculus. Now, it's not in the tract until it's going vertical. So as it's crossing over, it hasn't gotten into the fasciculus yet. But once it starts going up, it's now in that medial longitudinal fasciculus. That's going to take it up to the rostral midbrain, where it's going to leave the medial longitudinal fasciculus and go to the oculomotor nucleus, where it's going to tell that neuron going to the medial rectus of the opposite eye, you need to make this muscle contract. And so our lateral rectus on one eye and the medial rectus of the opposite eye both contract, and in this case, the eyes would move to the left. If I were stimulating the horizontal gaze center on the right side of my pons, that would go to the abducens nucleus on the right, and that would cause us to contract lateral rectus of the right eye, medial rectus of the left eye, and the eyes would move to the right. So you can see if I damage the abducens nucleus, I've taken out the cell bodies both for the red nerve and for the yellow nerve. And that is why neither eye moves past midline, because neither the lateral rectus or the medial rectus are getting the signals to move. So there's my injury, taking it out, abducens nucleus, boom, both the red and the yellow neurons are gone, and the purple isn't doing it, doesn't activate unless that yellow one makes it active. When we have a nucleus injury of cranial nerve 6, we may also have damage to cranial nerve 7 with its voluntary motor neurons. And as I showed you in that one image in the introduction, I drew that line coming from cranial nerve 7 and wrapping around cranial nerve 6 nucleus. And so if you damage the nucleus, the likelihood is you're going to damage the neurons from cranial nerve 7 that are wrapping around it. Again, it's one of those things I cannot explain. Why does God have those neurons wrapping around the cranial nerve 6 nucleus? Why don't they just head out laterally and get out of there? I don't know. So here's the picture showing we have our abducens nucleus. You can see the facial motor nucleus there. He just labels it facial nucleus, but it's the motor nucleus for voluntary motor. How those neurons wrap around the abducens nucleus. So it's easy to see where if you damage the abducens nucleus, you might also damage those facial nerve neurons. So the person might experience paralysis of the muscles of facial expression on the same side that they have the abducens paralysis. Here is another image showing where the abducens nucleus is, as well as the facial nerve. The abducens nucleus is shown in the teal color. The facial nerve is in pink. And again, this is specifically the voluntary motor neurons of the facial nerve. So you can, it's hard to see, but she has it labeled where the facial nucleus is located, that motor nucleus. But you can see by the pink arrow how the voluntary motor neurons come around and wrap around the abducens nucleus. It kind of disappears for a little bit there on this image. So this is an actual slice of a brainstem. So they must have been not quite level. But then the nerve reappears, and then it's going to exit more laterally out of the pons. So this is at the bottom of the pons. The other thing I just want to point out in this picture is you can see also in teal, next to the abducens nucleus, that medial longitudinal fasciculus. Now, those internuclear neurons cross to the other side. So if they were in the left abducens nucleus, which is the one that's colored in here, those internuclear neurons would cross over to the medial longitudinal fasciculus over on the right side. The one that's shown is the left one, but they're going to go over to the one on the right and then ascend up into our mesencephalon in order to synapse with the motor neurons to the medial rectus muscle in the oculomotor nerve. So when we have damage to those internuclear neurons, so the abducens nerve is fine, the abducens nucleus is fine, the oculomotor nerve is fine, the oculomotor nucleus is fine. What we've damaged is the medial longitudinal fasciculus. So in the previous picture that I had put together, that was in yellow. We have a condition known as internuclear ophthalmoplegia. Internuclear because it's an injury between the two nuclei, and ophthalmic means referring to the eye. Plegia is paralysis. So what we have is the inability to move the eye in adduction when voluntarily contracting. So we have abduction intact because our cranial nerve 6 abducens nerve is normal. But when you want to adduct the opposite eye so that the two eyes move together, it doesn't happen. I just want to emphasize that anything dealing with this internuclear neuron is only for voluntary horizontal gaze. If we're talking about spontaneous, the eye will still move. But so if you are looking at a small object close up, so you are looking at a coin and you're trying to see the date on the coin, okay, you will actually still be able to adduct both eyes because that's a different pathway. But if I ask you to follow my finger with your eyes, that's a very voluntary controlled movement, and that's when we see the problems with horizontal gaze. So the person, let's say we've damaged the right medial longitudinal fasciculus. The neurons in that right medial longitudinal fasciculus have their cell bodies in the left abducens nucleus, and they're going to go to the right oculomotor nucleus. So when you are asked to follow my finger to the left, because the abducens nucleus is fine, your left eye will look towards my finger. But because we've damaged the neuron that's going to tell the oculomotor nerve to make the right eye adduct, since that nerve has been damaged, it can't tell the oculomotor nerve to the right eye to adduct, and so the right eye does not adduct. Our oculomotor nerve and nucleus itself are good. They're fine. They're healthy. They're just not getting told the command. But under a more spontaneous activity like looking at that coin where you have to bring your eyes towards your nose, then we have a different set of pathways. So your oculomotor nerve gets a command from someplace else. And so the eye does move into adduction. So there's different processes. So again, I just want to emphasize that when we're talking about this horizontal gaze, whether it's a horizontal gaze paralysis or an internuclear ophthalmoplegia, we're talking about voluntary horizontal gaze and not more of a spontaneous kind of horizontal gaze. So here we're going to go with that similar drawing to what I had before, only this time instead of damaging the cranial nerve 6 abducens nucleus, where we damaged both the red abducens nerve and the yellow internuclear neuron, we're going to damage the medial longitudinal fasciculus on the right side. We get a signal to our horizontal gaze center saying, oh, follow the finger to the left. Stimulates the abducens nucleus, stimulates the internuclear neuron and the abducens neuron. The abducens neuron goes to the lateral rectus of the left eye and makes it abduct, no problem. But the internuclear neuron is damaged in the MLF, so it's not able to give the command to the oculomotor neuron. So the oculomotor neuron doesn't do anything. It just sits there. So the right eye does not adduct when the left eye is abducting. With lateral gaze paralysis, remember, because we damaged both the yellow and the red, neither eye moved to the left. In this case, the left eye moves to the left, but the right eye doesn't. So that's the main difference in what you see. And it's very common to do what's called an H-test screen. With an H-test, you take your finger in front of the person's face, you have them look at your finger, and then you move it first to one side and then up and then down. And then you bring your finger back to the middle, and then you go to the other side and then move it up and move it down. And by doing that H test and seeing if the eyes follow your finger in all directions, you are actually testing all 3 cranial nerves for the eyes. You're testing, as you go off to one side, you're testing the abducens nerve and nucleus on that side. When you go up, you're looking at oculomotor and superior rectus. When you go down, you're looking at inferior rectus. And then you're repeating it on the other side for the other eye. So that simple little H test, this is what you look for. Do both eyes move past midline? If not, which eye doesn't? And what happens to the other eye? Does it move past midline, or is it only can get to midline and then it stops? And that can really help us to understand if this person has an injury and where it might be. As an occupational therapist, you are not going to be diagnosing these things, but you may be working with people where these visual deficits are interfering with their occupation. And so understanding the diagnosis, if you get somebody with a diagnosis of internuclear ophthalmoplegia, and being able to understand what that looks like, and so what problems this person might have, like with double vision, or but only in one direction, or being able to assist them in techniques to help them be able to carry on their occupations, as opposed to if the abducens nerve itself is damaged. That's going to look a little bit differently, and you might have to do something different to help them out. So, so from an occupational therapist standpoint, I'm asking you to know this not because you are going to be screening and diagnosing, but because understanding these conditions will help you to better assist your patients who have these conditions. And this is just a website that discusses a bit more the internuclear ophthalmoplegia, but having adduction on convergence. So in other words, when looking at that small object, the eye does adduct past midline, but when asked to follow, I don't remember if they're following a finger, following a pen, but following a light, but that the eye does not do so.